Today, I, Dr. Harpal Singh Malhotra, on behalf of AstraZeneca, welcomes you all. And in our endeavor to disseminate science, we have two distinguished speakers with us, Dr. P.C. Manoria and Dr. Tani Nair. And this is also, a great moment for us since dapagliflozin has got a US FDA approval in the month of May. We have got a BGCI approval in this month only on 2nd of July. And this is a proud moment for us. So without any delay, I will welcome today's first speaker, who is a renowned cardiologist. Not only he's having national repute, but he's of international repute as well. And he has been past president of CSI. He's currently director of Manoria Hospital, Bhopal. He has been former professor and HOD GMC Bhopal. He has also been past president of API. And I already told you that he was past president of CSI, Cardiology Society of India. He's chairman of Hypertension Council Asia Pacific Society of Cardiology. He has been there for quite many years. He has been vice president of SAC Society. Apart from these, he has been, it's a very vast CV. And I don't want to waste more time on that, but is a very distinguished and passionate cardiologist. He has authored many books, many publications, and he has been principal investigator for many trials. So over to you, Dr. P.C. Manoria.
Thank you.
For the talk.
Good evening, everybody. Today, I'm going to talk on heart failure burden in India, the current limitations of heart failure management. All of us know the statistics for heart failure are horrifying throughout the globe, including our country. Currently, we are harboring about 8 to 10 million patients of heart failure. And what is very distressing is India has a relatively young population of heart failure. About 22% are below the age of 30 years. Heart failure in India has a high post-admission mortality to the tune of 20 to 30%. And the medical duration is also 25 to 50%. What is still very, very distressing is the incidence of diabetes in the tremendum heart failure registry is to the tune of 54%. And why diabetes is so important in the context of heart failure? Because diabetes and chronic heart failure go hand in hand. Diabetics have increased risk of heart failure, and patients with heart failure are at increased risk of diabetes. Another thing we must understand in heart failure is there is a close link between heart failure and kidney disease. 1/3 of patients of heart failure have CKD at the time of diagnosis, and worsening kidney failure worsens heart failure and vice versa. Now, this shows the Indian data compared to the US and Europe. As you can see, Indians' heart failure occurs at a younger age. The ejection fraction is comparatively less. Mortality is more. Rehospitalization is more. And the post-discharge mortality is also higher. And uncontrolled hypertension and IIT are the major contributors to heart failure. In our country, RHD also contributes about 8% or so. Now, when we compare the Indians versus the Westerners, Indian patients present with heart failure as a younger age compared to the West. And as heart failure presents about a decade earlier in Indians, it generally strikes patients in their prime of lives. The majority of Indian patients belong to the low socioeconomic status, and they have to pay for the treatment from their own pocket, unlike the West. The male to female ratio is different in India, 70 to 30 as seen in the THFR, and 83 to 17 as seen in the Medanta registry, compared to the West where it's 1:1. The etiology in India is also different from the West. Besides CAD, hypertension, as we said, RHD is also a contributor to the tune of 8%. The prognosis of heart failure in Indian context appears to be worse than in the West. The in-hospital mortality observed in the THFR 8.4%, which is just double to that is reported in the ADHERE registry in the West. Now, the one-year mortality is very distressing. You can see 30.8, 23.3, 17.3 as per the THFR, inter-CHF, and the Medanta registry. And survival in heart failure is worse than even in some of the common cancers, as you can see on the slide. This applies both to men and women. And when we look at the 1 year, 5 year, 10 year survivals, you can see at 1 year, the survival is 81% compared to 94%. At 5 years, 51% and 74%. And at 10 year, it is 29 versus 54. What again worries us very much is that in diabetics with heart failure, the survival, 5-year survival is only 10%. 1 out of 4 patients have another hospitalization for heart failure within 30 days. And the big message for hospitalization for heart failure is every hospitalization, every rehospitalization takes the patient closer to death. So one of our important aims in the treatment of heart failure with others is decrease hospitalization for heart failure, because the median survival, as you can see on the slide on the right side, progressively decreases after each hospitalization for heart failure. If you get hospitalized because of heart failure, the mortality is more compared to another patient who does not get hospitalized because of heart failure, but for some other reasons. Heart failure also disturbs with the quality of life, and you can very clearly see in this patient that patients with NYHA class 3 heart failure were associated with significantly reduced SF36 scores compared to patients even on dialysis or those with hepatitis or major depression. And the SF36 average score for the entire heart failure population was also significantly lower compared with patients on dialysis, hepatitis, or major depression. Now, what is very important to remember in heart failure is that heart failure, once sets in, it runs a malignant progression with a very high morbidity and mortality, which you've already seen. Pharmacotherapy can only blunt this malignant progression. It cannot arrest it. And therefore, prevention of heart failure has emerged as a big agenda in the management of heart failure. The other thing we must always remember in heart failure is chronic heart failure is never a stable disease. The malignant progression continues because there is apoptosis of the myocardial cells as evidenced by persistent low-level elevation of troponins. The arrhythmogenic potential persists more so in stage 2 and 3 heart failure, and you can get admitted in the hospital without any anticipation. And all the guidelines are laying a lot of emphasis on prevention of heart failure. As you can see in this ACEIs, stage A heart failure is a patient who has only risk of heart failure, no structural disease or no symptoms. It looks funny, but that should be the approach. Stage B, structural heart disease, but no symptoms and signs of heart failure. So prevention of heart failure should start in stage A and B and not in C and D, because then you have already lost the valuable period. And there is a very urgent necessity to disseminate the dicta of prevention of heart failure amongst the physicians, amongst the practitioners throughout the country. And this shows the graphic representation of different stages, stage A and B, where we must exercise strong preventive measures, and C is the symptomatic phase, and D is the last phase. Now, another thing which you must keep in mind whenever we ask as to which complication do you fear most in a patient with diabetes or even without diabetes, I think majority would respond to heart failure, heart failure. AMI, we have a quick fix in terms of a primary angioplasty or lytic therapy or a combined approach. You can greatly improve the outcome of these patients. Stroke, also we have a quick fix in time of lytic therapy or angioplasty, although this is not yet widely dominated in our country. And CKD, although we do not have a quick fix, but we have two revolutionary drugs, the RAS blockers, which made tremendous changes in the trajectory of CKD and slowed down the progression of GFR, and the SGLT2 inhibitors on top of it have further slowed down the trajectory of chronic kidney disease. And you will hear from Dr. Tiny Nair that DAPA works not only in diabetic CKD, but also in non-diabetic CKD. But when we come to the question of heart failure, there is no quick fix for heart failure, and it runs a malignant progression. You can only blunt its progress, but cannot arrest it. Now, when we look at the evolution of therapies for heart failure in the pre-sacubtril era, 1980 to 2014, prior to 80s, we had only digoxin and diuretics, and the treatment was mainly non-pharmacological. 80s, we have the hemodynamic decade, vasodilators, inotropes. They did not change the mortality. In fact, inotropes increased the mortality. And 90s, we have the neurohormonal decade, RAS blockers, beta blockers. Both of them are mortality-reducing drugs and had become the first and second pillar of heart failure treatment. 2000 was a device era. We had ICD, CRT, LVAD, and MRAs was also approved in 2003. So by the end of 2003, we had 3 mortality-reducing drugs, and MRAs become the third pillar of heart failure. 2010 onwards, we had the cellular era being kicked off for cell therapy and gene therapy, which is still ongoing. But from 2003 to 2014, no new mortality drug emerged on the scenario of heart failure. 2014, after 11 years, we had valsartan sacubtril, the paradigm HF trial, which was presented in 2014, approved for clinical use in chronic heart failure, reduced ejection fraction in 2016. And 2019, we had the PINE HF trial for ADHF, and it's also being approved. So we had 4 pillars of heart failure: reduced ejection fraction, ACE, ARB, beta blockers, MRAs, and ARNI. And 2019 initiated dawn of a new era. We had the landmark revolutionary DAPA HF trial, which we alluded by Dr. Tiny Nair, and DAPA became the 5th pillar of heart failure, and it has smashed the boundary between diabetes and non-diabetes. What are our current management practices in the country? Our aims in reducing the treatment of heart failure is to relieve the symptoms, improve the functional capacity and also the quality of life, and reduce the mortality and the remodeling which occurs in heart failure. Now, we have already talked about these drugs, but what is very important, that all these drugs are highly underutilized in the Indian context. This is the registry data from several areas, and you can see there is underutilization of pharmacotherapy heart failure for MRAs, as you can see in the Asian HF study, 61%, Trivandrum 45%, and if you look at the Medanta registry, MRAs are only 11%, and so on. So there's an urgent necessity to increase the use of these drugs. The use of device therapy in our country is dismal 1.5% compared to the Western figure of 35%. We have ICD, CRT, and LVAD. This shows the treatment of HFrEF. All of us are aware of this. heart failure preserved ejection fraction. We do not have any mortality reducing drug, and the treatment is supportive and symptomatic. And we have also the mid-range ejection fraction. And we should also treat the comorbidities as is enlisted on the slides. Now, diuretics are very important drugs to relieve the symptoms of heart failure because they decrease congestion, but they do not reduce mortality. Torsemide, furosemide, the loop diuretics are usually the first choice. And if resistance develops to diuretics, you should adopt the principle of sequential nephral blockade. The drugs can be started orally or IV depending on the condition of the patient, and they decongest the patient. Patient becomes less symptomatic, and electrolyte imbalance is an important side effect, and so also hypotension. Then we have the ACE inhibitors. All of us are familiar with the use of ACE inhibitors. What is very important to remember in ACE inhibitors is if the patient has LV systolic dysfunction, even if it is asymptomatic, ACE inhibitors must be initiated because it improves the long term of even asymptomatic patients with LV systolic dysfunction. And the usual precaution is titrate it slowly, electrolyte imbalance, hypotension, a watch on potassium and creatinine, and occasionally angioneuritic edema. ARBs are used if the patient is not able to tolerate ACB, and the same precaution applies as is for ACE inhibitors. Beta blockers are also very useful drugs. They are mortality reducing drugs, should be used in all patients unless contraindicated, and they are usually initiated when the patient is avolemic and can be used in atrial fibrillation as well as sinus rhythm. They are slowly uptitrated and gradually the doses build up. Bradycardia, hypotension, these are the usual side effects, and they should not be suddenly withdrawn. Hyperkalemia must be looked for, particularly if the patient is diabetic and CKD. ARNI is another very good drug. ARNI has evoked a new concept of multi-system neurohormonal modulation, never utilized before, and it has shown improvement on top of the first three mortality-reducing drugs. The usual precaution, of course, hypotension, hyperkalemia, angioneuritic edema, and the dose is gradually built up. And when we are trying to use drug, we have to look for hypotension. The usual precaution is taken before initiation. Check the hydration, minimize use of diuretics, nitrates, if possible, alpha blockers. You can switch from carvedilol to bisoprolol. You have to look at the creatinine levels, the potassium levels, and angioedema. Ibuprofen is also used in heart failure. If it is in sinus rhythm, if it is more than 70 beats per minute, and it can be combined with beta blockers, decreases hospitalization for heart failure and death due to heart failure, but not cardiovascular mortality. So we have the conventional therapy and also the newer therapy. ARNI was the first new drug which came in 2014, got approved in 2016, but it has its own problems. You have to look for hypotension, creatinine levels, hyperkalemia, and you have to gradually build up the dose. And it produced a 20% reduction on top of all conventional drugs in the primary endpoint of cardiovascular death and hospitalization for heart failure. 2nd July 2020 came with a breaking news when DCGI approved dapagliflozin for treatment of heart failure, reduced ejection fraction, diabetics as well as non-diabetics. And this is indeed a great achievement. And Dr. Tiny Nair will demystify the nuances of use of dapagliflozin in HFrEF. And I'm sure he will also discuss the precautions and the side effects that should be undertaken when DAPA is used. And I'm sure he will be looking towards his pleasures of expertise during this discourse. Thank you.
Thank you so much, sir, for such a lucid and elaborative presentation. There were a few hands also being raised, but I will request everyone to post questions in Q&A session. And I will go straight away with Dr. PC Manoria, since he's been waiting for a while. So I'll ask sir about now we getting the approvals for DAPA-HF and for the heart failure for HFrEF. So where should we place it? Again, the same question, but if you have some answer for diabetic and non-diabetic, and if you like to differ. So over to you, Dr. P.C. Manoria. Please unmute yourself and answer it. Unmute yourself first.
See, whenever we are treating heart failure, we must understand that we are dealing with a malignant progression, and we should try to initiate all mortality reducing drugs which have already been listed. The sequence of initiation may be different. So somebody is on the conventional 3 agents. If the patient does not improve, we like to shift ACEIs to ARNI, and then we may also like to add to DAPA. But which drug should be initiated first out of ARNI or DAPA? We have to look into a particular, it has to be individualized. Suppose there's a problem of hyperkalemia, we would prefer DAPA rather than ARNI. Suppose the BP is well maintained, we may prefer ARNI than DAPA. And so all will depend, but we must follow the rule of combination therapy as we follow in acute myocardial infarction and we follow in malignant conditions. Combination therapy will improve the outcome of these patients, will decrease hospitalization, will improve the quality of life, but there's a lot of resistance from the patient and even the physicians who are pushing in more drugs. But in heart failure, this is a malignant condition. You have to use whatever possible is available. If you look at the survival rate in diabetes, dismal, 15% at the end of 5 years. So one of the greatest enemies of treatment of heart failure is inertia to use combination therapy, trying to maintain that I have only mild symptoms, do not add more drugs. So if you want to improve the malignant progression of disease, you have to adopt a combination therapy. You have to use all these drugs. The sequence may vary depending on the subset of the patient. And the projected increase in survival, which was recently published in Lancet, if you are at age 55 years, you use all these drugs, the projected survival is 6.3 years more than we use the conventional 4 drugs, which means ARNI, MRAs, beta blockers. So if you add DAPA, there's an additional increase in the projected survival.
Yeah, thank you so much, Dr. Manoria. Dr. Tiny, you would like to add something to this, or your, your comment on this same question? Yeah.
Nothing. Absolutely agree with Professor Manoria on every count.
Okay. You any addition from your side?
No, nothing.
Okay. So a question to you, sir, Dr. Tiny Nair. There's a question on the chat box, and it says that which beta blocker you prefer for heart failure?
This is not a question of this context, but we should answer that. 3 beta blockers have been proven to be useful in heart failure. Carvedilol, bisoprolol, and sustained-release metoprolol. All 3 has been proven to be of benefit. There has been very little head-to-head data to say which is better than the other. But the point is, if the patient is extremely sick, it is easier to start on a very small dose of carvedilol, like 3.125. You have very small dose of carvedilol to start. You can also start on very small dose of bisoprolol, like maybe a 1.25 of bisoprolol, which is also available. If patient has something like in bronchospasm, we tend to choose a more selective one like a bisoprolol. If not, we tend to choose carvedilol and then gradually push it up. But then again, those who are recovering from an MI, for example, or had a recent background of an ACEs very clearly shown, people tend to go in for sustained-release metoprolol, because in India, by our teaching and by our nature, we have been using metoprolol for such a long time for ischemic heart disease that we have just transferred that knowledge onto heart failure. But all 3 you can use. Nebivolol has been used in one trial called Seniors, but in that there is no mortality benefit. So we don't recommend nebivolol for heart failure. Hypertension is different ballgame. So your question answer in one single sentence would be that sustained-release metoprolol, bisoprolol, or carvedilol would be the 3 approved beta blockade for heart failure. But be very careful in slowly increasing the dose so that you don't really worsen. Understand that for a failing heart, there are just 2 walking sticks. Like one is an renin-angiotensin and the other is a sympathetic system. So the system is trying to compensate by holding on to that. Okay, but in the long run, if we let him continuously walk on a crutch, he will fail. He will become a fellow on a crutch, right? So we are slowly trying to remove it, but extremely careful so that you don't worsen a heart failure.
Yeah. Thank you so much, Dr. Tiny. So coming back to Dr. Manoria, I remember vividly you telling me one case where DAPA was added to standard care of treatment for your patient, and the patient was recurrent heart failure. It was around March this year. So something, sir, similar eureka moments you had in practical life with the use of dapagliflozin, which you would like to share on enlighten the audience today?
See, this was when DAPA was not approved
Yeah,
in
I
India,
remember.
but
Yeah, I
the
remember.
patient was getting repeatedly hospitalized and we were not able to prevent his rehospitalization. And when we added DAPA, he remained symptom-free at least, and he has not come back and is still alive. So that was just a last resort. It's an off-label indication, but we were not left with, he had undergone angioplasty, revascularization, ejection fraction, where he every time getting readmitted. So that was, and it worked. But this is an anecdotal, but now it is approved, we will be having more experience with it.
Yeah, yeah. Sure, sir. Dr. S.K. Prashar from Bhopal has a question for Dr. Tiny Nair. He says that in initial stage of heart failure, can we use both ARNI and DAPA together?
Yeah, that's a very interesting question. Now, see, the thing is, as our knowledge base increased, we started from a point where if the patient is symptomatic, we add an ARNI and we benefit. Okay, but look at from today's point of perspective. We have very clear data that ARNI improves survival. Okay, and that improvement is there in every category of heart failure. Similarly, we know that DAPA has shown that in class 2 and class 3, very clearly, it improves outcome by way of reducing mortality and reducing predominantly heart failure hospitalization. So if we believe that, we are trying to dissociate between the symptoms of heart failure and the outcome. So if we are looking only at symptom, it's different. If we are looking at outcome, it's different. So when I look from my point of view as a doctor, I would say that these two therapies, new therapies, reduce hard endpoints. So I would want my patient not to get to the hospital. I would want my patient to live longer, right? So these two therapies should be given as early as possible. And individually, after the transition data and that DAPA-HF sub-analysis, we know that earlier you start is better. But again, there's a point of caution. If you look at that 11% of patients who were on ARNI plus DAPA, you see that the confidence interval was very large, right? And one end you have a confidence interval of 1.13, which means there is some patient where there is a chance that there is a 13% worsening of outcome. Okay, so you have to be extremely careful in picking and choosing as to which patient you should give a combination of ARNI and DAPA. But I think if you choose correctly, a patient who tolerates both without change of blood pressure, he doesn't get dehydrated, his electrolytes are fine, his creatine doesn't go up, he actually would probably do better in the long run, whether he is class 2 or class 3.
Yeah. Thank you so much, sir. Very elaborative answer for that. Now coming to Dr. Manoria, sir. Sir, another study also suggested that dapagliflozin in DAPA-HF trial reduced diabetes. There was an analysis from that diabetes occurrence by 33%. So there's a question that can we consider DAPA as a diabetes prevention agent in pre-diabetic population? Since you have authored diabetes cardio-diabetic drug books also, I think no one can answer better than you regarding this. Please, sir, go ahead.
This was a subgroup analysis from DAPA-HF, but the data has to be confirmed in a larger trial, randomized trial, before we can finally say. The data is certainly exciting, and this was a subgroup analysis from DAPA-HF.
Right.
Can I add a point here?
Please, sir. Please, sir.
For example, see, it's very funny, like Professor Manoria said, it's very funny that if you look at the data of ARNI, for example, ARNI has shown that in the long run, ARNI reduces HbA1c, right? And ARNI, actually, those patients who are on ARNI in paradigm, the subset they analyzed, they found that their need for insulin coming down. So we say that, you see, ARNI is a heart failure drug. It is shown to be beneficial in diabetes. And DAPA, which was a diabetic drug, shows benefit in heart failure. Get the point? So, and if you remember the very second slide that Professor Manoria showed, it's so very important that heart failure and diabetes are connected to each other. The patient who goes in for a heart failure has a higher chance for developing diabetes. And a diabetic, obviously, we know that he has a higher chance for heart failure. So, we don't know what prevents what, but we know they're intermingled. And if a drug that is metabolic friendly probably tends to prevent both. And with the nature that it reduces obesity, and that it has a natriuretic and a glucosuric effect, obviously DAPA might be a drug that if you give to an IFG, you would probably not become diabetic in the future, number one. And second thing is, for example, many people today, a lot of people go for echo, right? We do an echo. And many people come for an echo and we find that the ejection fraction is, say, 45%. But the patient is healthy, right? So asymptomatic left ventricular dysfunction. And hardly any of them get recognized by the physician and get treated because there's no feature of heart failure. And that is where that subgroup B that Dr. Manoria showed, that they should be on a drug. Now, if this patient has IFG, what would you write and I write? You would put him on a DAPA, right? Because he has IFG or he has got an altered glucose tolerance and he has chance of becoming a diabetic on one side and he has little left ventricular dysfunction. And I know that this is one drug which will take care of both. Okay. Second thing, I always say that patients who are in post-CABG patients always come and say that, oh, I am fine. They don't even think that they have a disease. Doctor Saab, I had a CABG. How can anything happen to me, right? And these patients, if you do an echo, many of them have a little LV dysfunction. So these patients need two things. One, they should not develop atherosclerotic disease later because atherosclerosis is progressing. And the person thinks that after bypass, I am fine. And he has a little LV dysfunction. So what drug? SGLT inhibitor, dapagliflozin. So there are certain areas where you should focus, especially from a company side where you are so academic. You should take out these kind of subset and educate physicians that these are things we miss out. And probably these are patients who do so well with dapagliflozin. Because understand this drug is costly. Okay. But a person who has undergone CABG, he can still afford to take it. He may not be aware that he has any problem.
Right, sir. Thank you so much. So one last question. We have one more, which is not related to DAPA, but I will take that later. But sir, coming before that to DAPA, Dr. Tiny also showed the benefits on the renal thing slightly. And now DAPA CKD trial has also been prematurely stopped, showing overwhelming benefits. So Dr. P.C. Manoria, how it excites to a cardiologist, seeing having the same molecule having a lot of renal benefits as well. So what's your take on that? Would like to enlighten, please, sir.
If you go down the memory lane, the normal fall in GFR per year is 0.9 ml per minute per year. When diabetes developed CKD, the average fall was 10 ml per year, and lots of patients were submitted for renal transplant and dialysis. The first revolution in CKD came when RAS blockers were introduced in 2005, and they slowed down the declining progress of GFR, and that made great difference. And the GFR, which was about 10 ml prior to DAPA, it decreased down to 4.4. And when SGLT2 came in around about 2005, they further changed the trajectory of CKD, and from 0.4, it came down to 1.85 or 58%. And you will be very interested to know that now data is coming with non-steroidal MRAs. The two trials are going to be presented shortly. We have another third drug which will further slow down the trajectory of kidney disease. So although we do not have a quick fix for CKD, we already have two revolutionary therapies, and the third is also going to be presented in the American Society of Nephrology. That's why diabetes, the issue is heart failure, kidney disease, and glycemic. DAPA is unique in the sense it is good for heart failure, both diabetic and it is good for CKD, diabetic and non-diabetic, and it produces glycemic control and at the same time improves the cardiometabolic profile by decreasing weight and also minimal hypoglycemia, and also decreases blood pressure. So DAPA acts on most of the phases of diabetes and is a good drug. We say DAPA is 3-in-1. Glycemic control, good cardiometabolic control, CKD prevention, heart failure treatment and prevention, as told by Dr. So DAPA is a good. And this is all approved indications.
Yeah.
And you cannot change DAPA with other SGLT2 inhibitors, particularly EMPA, because EMPA in the Imperial trial has not shown favorable data.
Right. Wait for more data. Thank you so much, sir. A very elaborative answer. And I know that you get excited. I can see that, and the audience can also see that. So, but now next question from Dr. MC Agarwal from Bhopal. I will cross transfer it to Dr. Tiny Nair. He says, what about the preserved ejection fraction and DAPA's role in that? I will also combine Dr. Asha Murthy's question from Chennai. If you can comment on Paragon trial also a little bit. You can take this question combined together. Dr. Tiny Nair.
Right now, in a non-diabetic, we have no data on preserved heart failure. So very clearly, there's no data to say that you can write DAPA for a person who has got no diabetes and a preserved ejection fraction heart failure. There's no data. But the point is, try to understand a couple of things. Preserved heart failure is not one single disease, right? Preserved heart failure is something where either the myocardium is thickened and there is a problem between the myocardial energy demand and the energy transport. So there may be ischemia, there may be myohypertrophy, and the myocyte doesn't relax properly and you have heart failure. So basically you have good ejection fraction and the patient has clinical features of heart failure with elevated end-terminal propain pain, whatever it is. No single drug as of now has shown that it is absolutely beneficial in terms of preserved heart failure, ejection fraction and heart failure, HFrEF. We need to tackle the hypertension. We need to tackle his ischemia. We have to treat AF if there is one. If there is obesity, we have to reduce body weight. If he has OSA, we treat that and just give supportives. Neither MRA nor beta blocker nor digoxin, diuretic, anything is proven. But standard therapy would be a small dose of diuretic. Try to control the heart rate if the heart rate is fast. And of course, treat ischemia, hypertension, AF, OSA, and all these supportive things. But my take would be that in the long run, if you're considering one drug that is likely to show benefit in HFpEF, it is an SGLT inhibitor. Because SGLT inhibitor has all the benefits, including your sodium, hydrogen, whatever you talk about, NHE and all that. But more importantly, it tends to reduce the myocardial interstitial edema and tends to make the myocardium more supple and more able to relax well. In fact, there is some data which has come from Ontario, from Dr. Suvad Verma's group, on experimental animals showing that even in the absence of reduction of LVH, even with a similar maintained blood pressure in a rat model, there is benefit in HFpEF with SGLT inhibitors. So I'm excited about it. But only thing is, you should not expect that your DAPA or any SGLT inhibitor very quickly will produce a symptomatic improvement or very quickly will take away an entire HFpEF. That is not possible. But in the long run, the symptomatic improvement is likely to come with SGLT inhibitor. Professor Manoria, can you comment?
Yeah, he wants to say something. Yeah, Dr. Manoria.
The time has come when you should try to assess systolic function by GLS. So some of these heart failure, preserved ejection in the borderline range may be transferred to heart failure with reduced ejection fraction. The second thing is all drugs which have failed in HFpEF act through the neurohormonal pathways. DAPA, we know it has shown improvement not through the neurohormonal pathways, but by a new pathway for management of heart failure. And the declaratomy has some patients of preserved ejection fraction, they have shown benefit. So hope is there, but the reality will come after the delivered trial.
Yeah, sir. So thank you so much. I think it answers very well. And I think all the cardiologists and physicians who have joined, they will be hopeful and we'll see, because COVID era is also, taken us into a ditch, and we'll be hopeful and we'll survive this COVID pandemic as well. So last comment, sir, before we end today's session, we'll start with Dr. Tiny and then we'll come to Dr. PC Noria. Dr. Tiny, last comments for the day.
You mean something like take home?
Maybe.
This is a drug that we are all excited about, and we think that it has actually created a change in our practice outcomes, right? There are a lot of drugs that come on the fringe and, plus minus and all that. See, for example, a new antiplatelet, you may not be able to see its benefit in your clinical practice. But SGLT inhibitors, for example, dapagliflozin is one where you can actually see with right in front of your eyes, the glucose improving, the patient tending to not gain weight and lose some, blood pressure stabilizing, heart failure improving. So I think we are very excited about it, and I think that this would change the entire way we look at heart failure, and probably the future heart failure registry trials will show, the data will show that the outcome is not as bad as we found in the random heart failure registry.
Thank you so much. And Dr. P.C. Manoria, last comments from you.
DAPA at the present state of time, when we look at the evidence, seems to be a gold standard because it has an approved indication for HFrEF. No other SGLT2 inhibitor is approved. It is the first SGLT2 which has shown benefits in non-diabetic and diabetic heart failure. And also in CKD, the trial is going to be presented that it has benefit in CKD diabetic versus non-diabetic. And another thing is that it is poised to change the definition of refractory heart failure. Now, prior to DAPA, whenever we submit a patient of HFrEF to a device therapy, we will ask, have you taken ARNI? If he has not taken, we say, take ARNI and come back. Now we'll say, besides ARNI, have you taken DAPA also? If you have not taken, take DAPA and then come back. So all these indications for device therapy, CRT and others, perhaps would be, again, should be reviewed, but I don't think they will be reviewed. But from a practice point of view, we will always take DAPA and then come back for a device therapy. But all of them are costly, and the use in India, and we have said only 1.5% this month. So that is another big change which is going to come. It is going to postpone the device therapy, at least for in future. So that is another big message coming from DAPA HF.
Absolutely.
Yeah, thank you so much, sir. I would like to invite now two of my colleagues. I'll start with Yogesh Belagali, Dr. Yogesh, for the vote of thanks and concluding remarks. And one from marketing team, please, you can also unmute yourself. Yogesh, you can start, please.
Thank you, sir. Thank you, Dr. Tiny Nair, Dr. Manoria. It was a pleasure listening to you, and we have had the pleasure of listening to you, I think, post-lockdown, probably 2 times. And every time, I think there's a new thing to learn from both of you. Last time it was Dr. Manoria speaking on DAPA HF, and this time it was Dr. Nair speaking on it. And a lot of new insights into this, which I'm sure the entire audience has thoroughly enjoyed it with the discussion. Something which Dr. Manoria said, that it has shattered the walls and the new gold standard. So these are very encouraging words, sir. I hope that this will prove to the beneficial to the patients, because ultimately it is the patient that comes first. And we are really grateful that you took time out of your busy schedule on a Friday evening here. But I'm sure, sir, you must have enjoyed it, and we all and all the entire audience here that is that are gathered have learned a lot from you, sir. Thank you, and would be looking forward to many more interactions, and hopefully we can meet each other in the near future when this all subsides, and do a namaste in person, sir.
Sure, Yogesh. Thank you so much. Over to Manoj. Manoj, can you make a quick?
I request Dr. Gaurav to share the vote of thanks.
Right. Okay. Go ahead, Gaurav. Dr. Gaurav, please.
I think, sir, I will be very quick, sir. Thank you, Dr. Manoria and Dr. Tiny Nair, for such a wonderful presentations. I wouldn't say it's a presentation. I think what we were going through was a live case, how a heart failure patient suffers from a burden perspective, and then putting across what could be the new mechanism, and combination therapy is what is needed. And sir, cherry on top was the live example of Dick Cheney and how he was suffering. That suffering came across, and I think that's what I take across. And sir, as a team, we are working towards to help heart failure patients unfail and have better outcomes for heart failure patients. Thank you so much, sir, for your time today, and we'll look forward to more participations and more sessions like this.
Thank you.
Thank you so much.
Thank you so much.
Thank you.
Bye.
Stay safe, stay
Bye,
healthy,
bye,
and
sir.
stay strong, everyone.
Thank you. Bye bye.
Thank
See you.
Thank you
See
so
you
much.
at Bhopal.
Thank you. Yes, sir. Thank you. It's a good session, sir, Dr. Arpan.
Yeah, it was good session.
अच्छा हो गया 1.5 hours, and I think it was not fatigue. मतलब कई बार क्या होता है, लंबा होता है session, तो sometimes it's fatigue, but it was good.
Dr. Kagina was also very passionate, and if you see, they have categorized the values. If you go deep into it, if you really mean and if you
Right. Chalo. Bye. Good night. Thank you,
Maybe, Rajesh,
Rajesh.
close it.
Thanks,
Thank you,
Rajesh,
sir.
for all your help. Yeah. Fine. I think she will close. Thanks.